All right. Well, thanks everyone for coming. I'm going to talk to you today about some of the work that I've been doing. I'm a PhD student. I'm about a third of my way into my candidature. And I've been working on a project about smoking cessation care in oncology. And today I'm going to talk to you about how a patient perspective fits into this. I wouldn't be able to talk about it, however, if not for the support of the partners listed at the bottom of the slide there. So thank you to them, and also to the Cancer Institute for putting on such an interesting to me particularly, conference today. So I'll skip through some of this because, as we heard from Graham and others this morning, you've heard a lot about the background, and smoking cessation is important. So I guess the main reasons for this project in itself was there's a limited literature in an Australian context about patient receipt of smoking cessation care. And when we talk about smoking cessation care, we're referring to the three ask, advise, refer model, which some of you are probably familiar with. So are patients asked about smoking status? Are they advised to quit and advised about the benefits of cessation? And are they referred to external supports? And there is some great stuff that Graham has led, some international data coming out, but like I said, in an Australian context, it's a little bit lacking. So we've tried to address that dearth. So the aims of this project was to firstly identify the prevalence of smoking cessation care provided to cancer outpatients. We wanted to explore patient beliefs regarding the appropriateness and significance of smoking cessation care. If we're going to deliver it to patients, we want to know if they think it's appropriate as well. And finally, we wanted to look at patient knowledge of existing smoking cessation support services, so if they knew what was out that they could link with. And to do that, we administered a survey to patients attending a medical, radiation or surgical oncology appointment across 7 different oncology treatment centres, which were located across 7 hospitals in New South Wales across a variety of LHDs. Patients were diagnosed with any cancer type within the previous 6 months at the time they completed their survey. And we invited both smokers and non-smokers to complete the survey. It took smokers about 10 minutes and non-smokers was a bit quicker. And we got patients that had previously attended the clinic. So we were asking them to report about any smoking cessation care they had received. And obviously it's a bit difficult to report on care you've received if you've not been to the clinic before. So the survey itself, we just administered via iPad or pen and paper while patients were waiting in the clinic for their appointments, and they were generally receptive for a distraction while they're waiting. And as well as demographic questions, it contained items relating to those 3 aims I talked about. So their reported receipt of smoking cessation care, their attitudes regarding the importance, appropriateness and significance of smoking cessation care, and what knowledge of system supports they had. And so just some descriptive results here. So we had 310 patients complete the survey with a response rate of 81%. Mean age was 60 years, majority were female. The most commonly reported cancer type was breast cancer, followed by skin and then lung. But like I said, we invited anyone with any cancer type, and we had a whole host reported, so head and neck cancers as well as cervical and things like that. We have a little bit more data cleaning to do to consolidate these answers, but at the moment we have about 60 different types reported, although that might be double ups, but there's still a host of cancer types included there. The majority were diagnosed between 13 weeks and 6 months when they completed the survey. And we had a smaller proportion than we expected of current smokers complete the survey, at 12%. But like Graham alluded to earlier, there's potentially a bit of a underrepresentation of true smoking status. Cancer patients might misreport their true smoking status, about 30%. So this is maybe an underestimation, but unfortunately we didn't have the means to include some biochemical validation. So we'll just go with a 12%. And we had another 10% that were smoking at the time of diagnosis, but reported they had quit when they completed their survey. So if we look at the results for that first aim about identifying the prevalence of smoking cessation care, so excitingly, 83% of patients reported they were asked about their smoking status. And that was for the 310 patients that completed the survey. But then when we asked people who were smoking at the time of diagnosis whether they received advice to quit and whether they were referred to services to help them, so that was a quit line or a GP or an Aboriginal medical service, about half said they were. So that's, I guess you can look at it a positive and a negative way. So 50% is better than what we expected, but it's still a vast range of improvement to go. And then if we look at the results for that second question about whether patients thought smoking cessation care was appropriate. So here we asked patients to agree or disagree to a range of statements about the smoking cessation care actions. So if they believe people should be asked about smoking, if they should receive advice, and if they should be referred. And it was just a 5-point Likert scale from strongly agree to strongly disagree. And I'm just going to present the proportion of patients who selected either strongly agree or agree, because as you'll see, there's a great overwhelming majority of patients that thought, yes, I'll strongly agree or agree to these actions. So for ask, for smokers and non-smokers, it was over 90%, and advise and refer over 80%. And interestingly, that's for smokers and non-smokers as well. So smokers in the blue columns and non-smokers in the orange columns. So that's the exciting result. And then we asked about the beliefs regarding the significance of smoking cessation care. So again, we asked them to agree or disagree to a range of statements, including quitting smoking after diagnosis can make treatment more effective, if there was a point to quitting smoking if they had cancer, and if they need support to quit from people who know about treatment. And again, I'll show you the proportion that reported strongly agree or agree. And we can see there's a similar agreement between smokers and non-smokers for each item. 60 or just over 60% for treatment effectiveness, about 70% for if there was a point to quitting smoking, and close to 80% or just over 80% for a need for support from people who know about cancer treatment. And then that final question about whether they knew about existing services that were available to them. Again, that 5-point Likert scale of agree or disagree, and we presented statements like, is the quit line effective in assisting people with cancer to quit smoking, and whether existing services did meet the needs of patients with cancer who wish to quit smoking. And I'm going to talk about the proportion who reported unsure here. That's because that was the greatest proportion that we saw in the data. So 60% or 55 to 60% didn't know about the quit line, and a larger proportion for the existing services. So that's perhaps not surprising that non-smokers don't know about existing services and quit line, but it is surprising and probably alarming, or hopefully alarming to some of us, that smokers don't know about existing services that are out there either. So just a quick summary in terms of that first question about the prevalence of smoking cessation care. So patients were asked about smoking status, and that's all patients, but for those that were smoking, there was limited engagement beyond this point, so they received limited advice and limited referral to external supports. Regardless of smoking status, patients are receptive to being asked about smoking, and they agree that stopping smoking has clinical benefits in a cancer context, and they want support they want to be referred to external supports. And finally, patients are unfamiliar with the external supports that they can engage, but that's perhaps not an unusual finding, and it's not just unique to oncology. Perhaps it's the case that generally some smokers aren't sure about what supports are out there unless you directly link them with it. So just some final concluding thoughts is that, so we know, and as we've heard today so wonderfully, that patient smoking status is a powerful risk indicator in oncology. What we need to do then is to find ways to provide evidence-based smoking cessation care to these people. That's very easy for me to say, but another matter to actually provide it and to link it. And that's an area, and we've heard from our fervent discussions this morning, there's a whole host of ways we can tackle this, and that's what we should endeavour to do, and that's what I'm going to try to do in the rest of my PhD. So that's it from me, other than to say thank you very much again to the partners involved in the survey, to the patients who completed the survey, and people who facilitated data collection. Thank you.